The height of the effusion is determined by auscultation and percussion of the posterior chest wall. With a skin marking pen, mark the needle insertion site. The site should be 5 to 10 centimeters lateral to the spine and at least 1 or 2 intercostal spaces below the top of the effusion. The needle should not be inserted below the 9th rib. If available, bedside ultrasonography can be used to help visualize the effusion. In the patient in this video, the pleural effusion is easily visualized, as are the ipsilateral lung and the liver. Prepare the area with antiseptic solution and apply a sterile drape. Using a 25 gauge needle, place a wheel of local anesthetic such as lidocaine along the superior edge of the rib that lies below the selected intercostal space. Switch to a 22 gauge needle and begin to anesthetize the deeper tissues. The inferior surface of the rib must be avoided, since the intercostal vessels and nerve are located in this region. At this point, walk the needle over the superior aspect of the rib, alternately injecting anesthetic and pulling back on the plunger as you advance. Once the needle enters the pleural space, pleural fluid will begin to fill the syringe. Inject more anesthetic at this point to anesthetize the highly sensitive parietal pleura. Note the depth of penetration and then withdraw the needle. If available, a hemostat may be attached to the exposed portion of the needle to mark the depth of the pleural space. Attach an 18 gauge over-the-needle catheter to a syringe and advance it along the superior surface of the rib. Keep pulling back on the plunger as you proceed to the predetermined depth of the pleural space. Once fluid is aspirated, immediately stop advancing the needle and guide the plastic catheter over the needle. When the catheter is fully inserted, remove the needle as the patient exhales or hums. The exposed hub of the catheter should be covered immediately with your finger to prevent the entry of air into the pleural space. Next, attach the 3-way stopcock and large syringe to the catheter and continue to aspirate fluid. When this syringe is full, adjust the stopcock so that it is closed to the patient. The stopcock should be open to the patient only when fluid is being actively drained. If additional fluid needs to be drained for therapeutic purposes, attach the collection tubing to the stopcock and to the evacuated container. Open the stopcock to the patient and to the tubing and allow the evacuated container to fill. Generally, you should remove no more than 1,500 milliliters of pleural fluid. The removal of larger volumes may result in post-expansion pulmonary edema. On completion of fluid collection, you should rapidly remove the catheter as the patient holds his or her breath at end expiration. Cover the needle insertion site with an occlusive dressing and clean the surrounding skin. At the end of the procedure, make sure that all needles are placed into appropriate safety devices. Aspirated fluid should be placed in specimen tubes before the large evacuated container is filled or while it is filling. A tube without additives should be used for chemical analyses such as the measurement of lactic dehydrogenase, protein, and glucose levels. An EDTA